Perfect. Fantastic. Now we can see the full screen.
Okay. So, as I say, we are a small service, but we've been around within NHS Tayside for quite a while. I've only been here for about 10 years, but when I back in 2014, I did an audit of our hormone deprivation cases, a 7-year retrospective that covered some of my colleagues' work. And so what I've done is I've done a slightly longer review this time that's taken me back effectively to 2006. And so that's the data set that I'll be sharing with you this afternoon. The key aims of our integrated service, particularly in respect of your cases, are improved quality of life, an improved tolerance of your conventional medication, and hopefully better rates of compliance with your anti-estrogen drugs and your aromatase inhibitors. And of course, you all know this very well. There's a big argument to try and improve tolerance and compliance, because there's a dropout rate in aromatase inhibitors of about 11% and nearly 14% in tamoxifen. And I don't need to tell any of you that this has implications for 10-year recurrence rates, probably in the region of around 12% or maybe 12.5%. So I do believe that whatever we can do as a team to improve compliance is important. And I'm very conscious of the high quality of the letters I receive from our breast care team, who are working very hard in person-centered medicine to try and improve the patient's experience of their treatment. Looking back over these, all these years, when I look at the hormone deprivation cases that I'm treating in total, we're looking at the majority of them coming from breast care services due to pharmacological estrogen blockade or the aromatase inhibitors. There's a smaller group of sort of natural menopause cases that are coming mainly through to us from primary care, but there are some, of course, who are coming with surgical menopause from after gynae tumours or gynae surgery. And so if we look at all those in all categories, it comes to about 303 patients over those years. But limiting ourselves purely to the tamoxifen and aromatase inhibitors groups, we're looking at 125 cases in this review and 47 cases for the aromatase inhibitors. And again, you'll be very familiar with the kind of tolerance issues that we're dealing with. And of course, the hot flushes and night sweats are predominating. But I was interested to see recently that one of the key reasons for people stopping was often due to musculoskeletal pain. And certainly there are a number of the cases in our review for whom that's been a problem. If we look at the homeopathic medicines that we're finding are most commonly associated with response, we have amyl nitrosum or amyl nitrate at the top, which is a material that you'll be familiar with, and followed by a number of others that we've found helpful for different kinds of clinical presentation. I think the amyl nitrosum actually presents us with a nice opportunity to try and describe what it is that homeopathy is about, really. It alludes to the fact that unstable systems are very sensitive to tiny stimuli. And of course, as you know, your patients who've got hot flushes and these sudden vasomotor effects, a few of them will be triggered if they have a hot drink, or a few of them will be triggered by exercise, and some others will be triggered by an anxious thought or a change in their mood. But for many of them, the actual triggers, what actually tips them over into the kind of hot flush fugue state, is such a tiny stimulus that it's actually, we're not really aware of what it is. And effectively, we're looking at a cascade effect. And these cascade effects in living systems appear to be due to a kind of fugue in the physiological systems of feedback and regulation. And what is important from our point of view, from our medical paradigm, if you like, is that these dysregulated systems are also sensitive to tiny harmonic stimuli that are somehow in phase with the problem or that mirror the nature of the disharmony. And I think it can be difficult, to understand that if you're coming from what is effectively materialist medicine, where you're trained really to block receptor sites and kind of manage symptoms. Effectively, what we're trying to do here is put in a stimulus that will actually reset the disturbed and dysfunctional feedback. And it is psychologically and philosophically a different way of managing symptoms. So you're all aware of what amyl nitrate does. We've seen it, the analogues of it, of course, in our GTN population who are on anti-anginal sprays, and quite frequently they'll get an ebullition, a flush up to the head, and a thumping headache. And amyl nitrosum is sometimes is used recreationally, occasionally as poppers. And of course, it's not the kind of experience that your middle-aged lady wants if she's sitting in front of a class, or if she's sitting in a consulting room, or if she's in a committee meeting. She certainly doesn't want to have a sudden, unheralded flushing episode with beads of perspiration and so on. So what we are doing effectively homeopathically is we're putting in microdoses really of this substance that can cause the problem, that can stimulate under other circumstances the problem, and effectively we're applying a homologous stimulus to try and reset or reprogram this situation. And this seems a little bit sort of counterintuitive to begin with, but actually it is a biological phenomenon that we see right across the biological world. And if you look at the work of Edward Calabrese, who in the United States, who's a toxicologist, he's identified that tiny doses of many of our environmental toxins actually have a paradoxical effect in living systems, in that they appear to improve tolerance to larger doses. And in fact, there are lots and lots of examples in the biological world of microdose phenomena, forms of hormesis, forms of signaling, that actually have disproportionate effects. But the question really has to do on whether or not ultimately the idea works in practice. And I think this is one of the things I'd like to try and convey in this case series that I've been looking at here. There are some papers in the literature that give an insight into the wider use internationally of homeopathy within integrative oncology. And these are interesting papers. They are not, of course, all double-blind placebo-controlled trials. Many of them are observational studies. But taken together, I think they do provide us with a good argument for potentially organizing a double-blind trial. There are some trials, for the treatment of skin reactions during radiotherapy. There's a randomized double-blind trial there. But we've still got quite a way to go before we manage to really get the evidence nailed for this approach. Nevertheless, looking at the 172 patients that I described at the beginning who have had either aromatase inhibitors or estrogen blockade of one kind or another, we're looking at about 170 in the review going back to 2006, of which 32 have been lost to follow-up, and I can't find any data that allows me to make any judgment for those cases. And that leaves us with around 140. And of course, because we're dealing with a spectrum of problems in which flushing is the main or the dominant problem, it is a bit difficult to find a kind of outcome measure that embraces the entire quality of life, the reduction of symptoms. I have used what we call the Glasgow score, and very roughly speaking, a +1 in the Glasgow score represents minor symptomatic change, but not affecting everyday living, so to speak. Whereas a +4 is almost a complete resolution of symptoms, with a return to normalcy, really, within the experience of everyday living. And of course, a 0 is no change, and there is a minus scale for people who appear to get worse or aggravate while on treatment. So it is a rough outcome scale, but it is actually quite easy to apportion these from patients' statements. So it's quite easy to apportion them to one or other of these groups without too much difficulty. And if we look at the homeopathic materials associated with response, there are 6 who are almost represent half our responders, of which a quarter are made up of the remedy that I've already mentioned, the medicine amyl nitrate, and another one here is Sanguinaria canadensis, which is this plant here, commonly known as bloodroot. And these 2 medicines between them represent a quarter of the recorded positive responses, with lesser proportions from Sepia officinalis pilocarpus, sulfur lachesis, and a number of others. We use Sanguinaria canadensis mainly when the patients are absolutely drenched with sweat at night. The amyl nitrosum, or amyl nitrate, is a medicine which is most helpful for daytime flushes where they're dry. There's a suddenness of onset and often an upward direction physiologically to their experience of the symptoms, whereas Sanguinaria tends to be more those patients who are completely having to get up in the middle of the night and change their night clothes. And pilocarpus, as a remedy, is most matched physiologically to those patients who've got head sweats, and where the flushings are almost from the neck upward, and that material tends to be used most often then. Of course, we are seeing quite a number of other problems presenting, and although quite a lot of our prescribing is aimed at reducing flushing and sweating episodes, because obviously if we can improve sleep patterns, then we can also reduce fatigue, and it may have a knock-on effect on mood changes as well. But we are actually seeing a number of patients where other problems appear to be freestanding and not just simply related to sleep pattern disturbance. And when I looked back through our data set, I found that there were at least 62 patients who were reporting pain syndromes as part of their difficulties, part of their problem. Either it was arthralgia or myalgia, mostly arthralgia, but there were a few that were having problems with post-surgical pain or post-radiotherapy symptoms. We also prescribed for them. Sort of in the other half of all those remedies that we've been applying, there are quite a number, and these all have different indications based on the dominant symptomatology and the way that the patient is responding to their environment. There is, to some extent, an attempt to provide individualized treatment wherever possible. You may be wondering, how on earth we managed to find our way through so many different materials with so many different variations on the symptomatology. Well, fortunately, nowadays we have decision support tools, and these decision support tools are based on data sets that go back decades. Effectively, a lot of our data sets relate to empirical observation, often in many patients going back a long way. And what we're interested in as medical homeopaths are the very specific sensitivities that people display. What predictors are there in the case that say that this patient will respond to amyl nitrate and this patient will respond to Sanguinaria and this next patient will respond to rust toxicodendron or whatever. And it comes out of the way the patients respond emotionally as well as physically. It comes down to the way that they react to their environments. It comes down to the pattern of the symptomatology in terms of the diurnal variation and the timing of their flushes in the daytime or accordance to eating, drinking, moving, or other physiological stimuli. And we use a refined information gathering to try and tie down what the main indicating features will be. And then we can use these computer data sets that will then match it up to clinical data derived from what we call proving experiments done on healthy volunteers with the baseline substances, or that also come out of clinical experience. And these really quite sophisticated computer systems can help us find a good match between our treatment and the patient. So again, just to reiterate, we're looking or aiming to get improved quality of life as far as possible by individualizing the treatment according to the reactions and responses for that patient. We're definitely trying to improve the tolerance of their conventional medication, and we're looking obviously for better rates of compliance. Trying to look at individual patient experiences, what I did was I tried from the data set to extract some cases where there seemed to be good follow-up. When I concentrated only on a subset of our patients, those that were purely presenting with flushing and night sweats and nothing else, no mood disturbances, no arthralgia, no pain syndromes, that cut the data set down quite considerably. And then when I looked at those patients where we had enough completeness in the records to really track a minimum of 6 reviews, then I plotted the individual patient experience from the first visit, which is the baseline for their symptomatology at 0, through to their experience over those 6 appointments. And you can see there are a couple of patients in this subset that didn't respond or even appeared to be slightly worse at the end of their 6 visits. But the majority of them have a pathway that takes them down to improvements in their symptomatology. And of course, the placebo response is pretty important and pretty powerful. And for those of us who are allowed to use it, it's a very important element in treatment. And I think it tends to be an underused treatment modality within conventional medicine. But not only this case series, but all the other observational studies do also support this idea that there is more going on here than placebo effects. This is a smaller case series done at the Royal London Homeopathic Hospital a number of years ago, looking at quality of life in an initial consultation and 3 reviews. And they found that the reduction in anxiety and the improvements in quality of life in this small observational study was statistically significant. So I think that what we do offer is a line of approach for a difficult caseload where there are limited treatment options available to these patients. And I think that we achieve a useful and meaningful improvement. The patients, I think, often feel well supported. They certainly feel listened to because we do look at their symptomatology in very fine detail. And I think that in itself is a helpful part of what we're trying to do for these patients. I was going to go on to look at 1 or 2 other things, including cost base, but really I think I've probably reached the end of my time, and if you would like to review anything in this presentation, you can scan this QR code, which will take you to a Dropbox to this presentation, and also it will also take you to some of the papers that I have mentioned as I've gone along here. I'm very happy to to take any questions that you'd like to pose.
Thanks a lot. It was really, really fantastic, to be honest. I must admit, I'm very ignorant about all this. I wanted to thank you because you see our patients very quickly, first of all, and a lot of these patients have been waiting maybe, well, I've been suffered with the symptoms for quite a long time. And then I noticed that whenever we refer you, the patients, you tend to see them within 2-3 weeks. So thank you for that. And also from our end, it's actually more the breast care nurses who see these patients. They tend to be very enthusiastic about meeting you, I think, for all the reasons that you mentioned, because they feel they are listened to, and also you can do something for them in a situation when they feel they are stuck and nobody can actually help them.